Then we will move on to the next speaker, Jörg Cammenga from Linköping, Sweden. His talk is on different mechanisms of SAMD9 and SAMD9L mutations in myeloid malignancies.
Thanks so much, and I would also like to thank the committee for choosing our abstract that was actually chosen for presentation. And this was a collaboration of many different groups, so I'm just presenting here the persons have done the work. I have nothing to disclose. Hematology has provided us with many riddles, and monosomy 7 is definitely one. We have been looking for 40 years for the genes, and I don't think we quite know yet which ones they are. And, you know, Weizmann once has said, I could only see further because I was standing on the shoulders of giants. And you can't even see me here standing on Frederick Lee's shoulders. He was actually a giant of medicine. He found the Lee-Fromeni syndrome, but what people don't know is he selected a lot of patients, families with cancer syndromes and tried to identify the genes, but he didn't have whole exome sequencing like we have today. So he described these two syndromes that not a lot of people are aware of. One is called ataxia pancytopenia syndrome, a syndrome where people get ataxia due to cerebral atrophy and pancytopenia. And the other one is called myelodysplasia and leukemia syndrome with monosomy 7. And then recently, a Japanese group and a group from the UK described the syndrome with multi-organ involvement called Mirage syndrome. And what these patients have is actually MDS, also with monosomy 7 infections, restriction of growth, adrenal insufficiency, genital hypoplasia, and enteropathy. What has been known to pediatric hematologists, which is kind of puzzling, if you look at pediatric MDS, you get 20% that have a monosomy 7. And in adult MDS, it's probably 5%. So why would a pediatric MDS population have a higher percentage of like a cytogenetic aberration that we normally associate with old age and genomic instability? What has been also known to pediatric hematologists is that there's a strange phenomenon called transient monosomy 7 in children. So patients that have often the pancytopenia and then develop a small subclone of monosomy 7, and then that strangely disappears and the patient often recovers miraculously and nobody knows what had happened. Then, of course, you know that aplastic anemia often progresses to MDS AML, and a lot of these cases have a monosomy 7 up to 80%. Then, of course, as you know, in adult MDS, there's monosomy 7, DEL7Q, and DUR17, and we're trying to identify the genes, and some of them have been identified. There's a genetic predisposition in MDS. We know probably a lot of the genes, but not all of them. And then there are these strange cases of GMML, where there's this microdeletion of 7q21.3, and there are only actually 3 genes in this region. I'm going to get back to that. So I'm not a magician, but at the end, I think I'll show you how this puzzle actually fits together. So it all started with a family that we had at Lund University. I was still working there, and it was a case of a 50-year-old man that has an MDS with a DUR17, and then we found out that his grandson also developed an MDS with a monosomy 7 at the age of 5. But interestingly, if you look back at the patient history, they all had monocytopenia, and they often had low NK cells. And the first thing that comes to mind is that this is a GATA2 deficiency syndrome, and we went into extensive length, also with help from colleagues from Hanover, to show that both alleles are expressed, so this was not GATA2 deficiency. And then we found another Finnish family, and the same, that often a history of transient pancytopenia, mainly thrombocytopenias. And then one in the family developed an MDS with monosomy 7 at the age of 2. So here's a little bit which kind of cellular deficiencies they have. Different ones, hemoglobin on the top, platelets, neutrophils, and monocytes. And in gray, you see the reference intervals. You can see that these patients have often like a complete absence of monocytes. They had normally very low NK cells, and they had very low B cells. So what you do today, if you don't know what happened, is you do whole exome sequencing, and we did this on germline materials, so we did it on fibroblasts, and what we found is like 2 different mutations in the 2 different families. So here are the 2 pedigrees. To the left is the family from Lund, and here's the family from Finland. We found 2 mutations, different mutations in SAMD9L. So that was interesting, but where is this gene located? And this gene is instantly located on chromosome 7q21.2. There are 2 genes, actually, one called SAMD9L, and one is called SAMD9. They're very homologous and conserved during evolution. There's very little homology to other genes, so it's very difficult to predict what they really do. The mouse doesn't have SAMD9, but the SAMD9L knockout mouse actually develops MDS with a quite long latency of up to 15 months. So what was weird is that when we looked what are these these mutations doing, actually, we found that they're slowing down cell cycle and proliferation. And how do you fit these things together? You have a SAMD9L mutation that's inherited, that's probably predisposing you to MDS, but it's slowing down cell cycle. So when you look back at the two cases in our families that develop MDS, here's the case that developed monosomy 7. And when you do the digital droplet PCR for like the variants, what you see is actually here the ratio between the two. So you would expect 50-50, and in the fibroblast you can see this. But then if the patient developed the monosomy 7, you can see that he lost the mutant copy. So you lose the mutant allele and not the wild type allele. So I thought first this was a mistake by the PhD student, but it wasn't. So then at the MDS it was the same. And then in the fibroblast you can see it's normal. Then the other patient developed this strange cytogenetic abnormality called DIR17, and he also lost the mutant allele. And how did that happen? Probably not everybody knows the DIR17, but this leads to a monosomy or a deletion of 7q and a duplication of 1. So therefore, like the mutant copy was again lost. So here are like some of the ratios, and this is always like in the blood of the patient. So what you could see here is there are some patients that didn't have an MDS with a monosomy 7 or another cytogenetic abnormality of chromosome 7 that had a very low variant allele frequency. That was the mutant allele was only at 20%, but they didn't have any hematologic disease. So how did that happen? And when you do phasing or SNP arrays on some of these patients that show very low variant allele frequency of the mutant allele, you find that there's uniparental disomy. So the mutant allele is lost due to the uniparental disomy, which is interesting in the blood. But in this patient also what we did is we went back, because in Sweden you can go back to the Guthrie cards. So at birth, actually in the blood, the ratio was 50-50, and the buccal swab was still 50-50, but later on, you can see it was the 20%. So at birth in the blood, there was a normal ratio. So this was an event that occurred later on. But then, strangely, there were some patients that were carrier of the variant, but were still not affected. They neither had like an MDS, monosomy 7, and they didn't have any UPD, but they had a 50-50 ratio. So why didn't these patients get sick? And what's interesting is, and Dr. Scherpik has already mentioned this, that there seemed to have been a protective allele in trans, actually, in these patients that protected them from getting the disease. And there's, in the other family cases, and we couldn't find there like this protective allele, but what we found is actually something completely different. We found somatic loss of function mutations in cis that neutralize the gain of function that the patient had, shown here. So it's a mutation upstream that basically results in this. So here's like testing the different variants, this what we call disease modifying, and this can be something what we call a protective germline variant, shown in blue, or the somatic reversion mutants of the ones that had been shown at that time. So they're in different patients, different reversion mutations, of course, and like I told you, in that one family, this protective germline variant. So then we wanted to look, where does this genetic reversion occur? And here we did cell sorting, advanced cell sorting for hematopoietic stem cells, multiprogenitors, CLPs, and CMPs. And you can see that, to my surprise, the genetic reversion occurred at the MPP level and downstream, but not at the HSC level. And here is sorting of more differentiated cells. And you can see that the lowest percentage of mutant variant allele is actually in the NK cells, because this seems to be most affected by this gain of function mutation, SAMD9L. Interestingly, SAMD9 and SAMD9L are interferon regulated, and that is important later on. So here we looked at expression of these two in CD34 cells, in NK cells, and fibroblasts. So you can see stimulation with interferon alpha and gamma, and SAMD9L and SAMD9 and an actin control in the respective tissues. So this is the model that we came up with, and this is really kind of an interesting thing, and it took us at least half a year and many different telephone conferences to come up with this scheme. So in the normal setting, you have a wild type SAMD9 or SAMD9L. Then if you get interferon stimulus, there's probably more protein made, and that seems to have some kind of effect on proliferation on the hematopoietic stem cells. If you have the gain-of-function mutation, this results in a lot of hyperactive protein and a gain-of-function expression of the protein. And this puts a lot of pressure on the hematopoietic system. So you see this in the form of a pancytopenia, inherited bone marrow failure-like syndrome. And you have 3 different possibilities now to rescue your hematopoietic system. Either you do a uniparental disomy and you exchange the mutant copy with the wild-type copy of the other parent, and then you will be appearing healthy and not really having a disease later on. You can acquire a loss-of-function mutation in cis so that you neutralize the gain-of-function mutation. And the last one is that you rescue your hematopoiesis by having a monosomy 7 deletion 7q or DIR17, rescuing your hematopoiesis at the price of developing MDS. And that's what we call this rescue by aneuploidy. It was interesting because when we looked at the patients, we found a uniparental disomy often only in 70–80% of the cells. And I remember me saying always, but that doesn't make sense. Why is that not a complete reversion? And Jeffrey Klockow and others have now shown that each patient has probably 10 to 20 different subclones where each cell has this own genetic reversion mechanisms, and they're just having such a gross advantage and take over. So the patients are probably a mixture of these mechanisms and different mechanisms. So then recently, when we found this, I actually contacted Jaroslav Machewski from the Cleveland Clinic because he has the biggest selection of patients with monosomy 7. And Yazoo, the postdoc on the project, did, of course, what every good postdoc should do. He didn't listen to me and did exactly the opposite. So I asked him to look for the 7q patients, but he looked for the whole MDS cohort. And what he found is actually quite interesting, and we wouldn't have found it if we wouldn't have done it that way. So here, what you see is the different genes. Here's the described mutants, and you see they cluster kind of more C-terminal. And the new mutations he found in adult patients are clustering more like N-terminal. And these are higher represented. Here you see some grafts. And this is probably because they are loss-of-function mutations. So in older patients, you find inherited loss-of-function SAMD9L and SAMD9 mutations. And they're often associated with other mutations that are known to be associated with MDS. So if I put the puzzle together, Frederick Lee described these 2 syndromes 40 years ago, and I think we know now that at least these 3 syndromes are all kind of related to each other. They're all gain-of-function SAMD9 and SAMD9L mutations, and the severity or the strength of the gain-of-function mutation probably predicts which kind of disease you get. The majority of the patient will present with inherited bone marrow failure, like a pancytopenia, aplastic anemia picture. The unfortunate ones will develop monosomy 7 that will be transient in quite a lot of the patients, and it's probably all due to mutations in SAMD9 and SAMD9L. And the very unfortunate ones, unfortunately, will develop in pediatric MDS with monosomy 7. And it's probably 30% of the cases of pediatric MDS, well, 30% are GATA2, and 30% we just don't know yet at the moment. And then we probably found new loss-of-function mutations, SAMD9 and SAMD9L, that predispose you to MDS at the older age. And I didn't tell you that in this region, actually, there are only the 3 genes, and 2 of them are SAMD9 and SAMD9L. So I think finally, after 40 years, we've solved the problem with many different groups have contributed to this. So why have we missed all this for 40 years? And I think it somehow relates to what Dr. Sherpak has told you. The high rate of somatic genetic reversion by either UPD or somatic loss-of-function mutation results in that it can jump over 1 generation. You can have either 1 family member, besides that this is an autosomal dominant disease, or there can be no family member actually be affected. Instead of gaining a somatic mutation, you lose a germline gain-of-function mutation. Once a patient has developed the disease with a cytogenetic abnormality of chromosome 7, you actually, the mutation is gone. So you can only look for it in the germline, or you find it at a very low mutant variant allele frequency. One interesting thing is that the SAMD9 and SAMD9L mutations that are germline, that are gain of function, are not very recurrent. And that has always been an argument of the reviewers, especially, that this can't be gain of function mutations. Here is like from a recent review from the Adelaide group, where they've shown this. So the one that are underlined are actually the rescue loss of function mutations, but the other ones are the ones that have been described as germline gain of function mutations. And you see that there is a variety of mutations, so it's not very recurrent. The genetic reversion clones by somatic loss of function mutation can be missed due to their small clone size, and that can be 2 to 3 to 5%, and you would probably misinterpret this as like technical errors in the sequencing. Germline loss of function SAMD9 and SAMD9L mutations are associated with a late disease and have probably been mistaken for like somatic diseases, similar to DDX41. So what does this mean for the clinic? And it's my last slide. All young patients, and we don't know really where to set the age limit, is it 45 or 50, that have an aberration of chromosome 7 should be tested, I think, for inherited SAMD9 and SAMD9L mutations, and of course for GATA2 mutations. Genetic testing should be, of course, performed on a non-hematopoietic tissue. Patient with inherited SAMD9 and SAMD9L mutation, gain of function mutation, and monosomy 7 should be analyzed for additional somatic mutations to evaluate the indication for allo. So this is always triggered for us when you see monosomy 7, that patient go to transplant. But here it's like what I call watch and wait for the UPD, hopefully. And then the related donors, of course, should be evaluated. And the meaning of their loss of function mutation, I think, remains so far unclear. So if I can see the future, I see this, a new like entity here. Well, we will see, I said 2023. So I think that will be maybe included in the WHO. So thanks for the attention, and these are the people who've done the work. It was a great collaboration between many, many really different groups, and thank for Yazoo for not listening to me.
Thank you. This talk is now open for questions. Anyone? Okay, I have a question for you, Jörg. Is it correct that those with the older patients with MDS and loss of function mutations, that they were kind of high-risk MDS patients? Many had complex karyotypes?
Yeah, that is still really confusing, because some of them had even like because normally it should be mutually exclusive with a monosomy 7, right? Because you would expect there's no pressure. There were some that they even shown actually as inherited bone marrow failure, like a plastic anemia, like. So I don't think we can say that much. It's very confusing, and we're like just trying to figure that out.
So they're very heterogeneous.
Yeah, exactly. No, I don't think there's no. There was some association actually, strangely, with 5q in some of these. Which I think is puzzling, because we don't really think that there's some kind of converging mechanism or like pathway.
Any other questions? Well, thank you very much for taking us through this complex story of SAMD9.
It gets even more complicated, but that I say for Toronto. Thanks.
Thank you.